Please let us rise.
It's lovely, Lord, you've kept the promise. Now we're singing, all dressed in splendor, as your promise again is kept. Oh, dear sweet rainbow, allure my feelings. Make so timeless. One race for zenith. We together began one day. You led me on as we've come this far. We fixed our shoulders and determined just to win. You led me on as the race was made. There to be. Anthem. Venomous whispers of disorders, Sieving the weeds from the Chaff. At this point, Mr. Vice Chancellor, members of the Governing Council, please permit me to invite your representative from the registrar, Mr. Adeseye, to come and invite the Vice Chancellor to the podium to lead the citation of the lecturer and declare this event open.
As this program progresses, it is my pleasure to invite the Vice Chancellor to go and read the citation of the inaugural lecture. Vice Chancellor, sir.
The inaugural lecture, please come over. This is the registrar of the university, the host, the university librarian, provost of the colleges, deans of faculties, dean of the postgraduate school, dean of student affairs, the royal fathers here present and their representatives, ladies and gentlemen. On behalf of the Vice Chancellor, I wish to read the profile of Professor Adeseye Abiodun Akintunde, the 64th inaugural lecturer of this great university. Professor Adeseye Abiodun Akintunde was born in Ogbomoso on Christmas Day, 25th December 1975, to the family of late Michael Adegboyega Kolawole Akintunde and Mrs. Felicia Longwe Faniran of Olosos Compound, Ara, in Egbedore local government area of Osun. He attended Baki Baptist Primary School, Ogbomoso, from 1980 to 1986, before proceeding to Ogbomoso Grammar School, Ogbomoso, from 1986 to 1992, where he won the best student in the sciences inter-school quiz competition, among other laurels. He was admitted to study medicine and surgery at Obafemi Awolowo University, Ilefe, 1993 to 2001, where he finished on the merit list. He had his mandatory housemanship at Wesley Guild Hospital, Ilesha, between 2001 and 2002, before proceeding to Federal Staff Clinic, Yola, Adamawa State, for his National Youth Service Corps between 2002 and 2003. Professor Akintunde had his residency training at Lautech Teaching Hospital, Osogbo, and passed the fellowship examinations of the West African College of Physicians and the Medical College of Physicians, Nigeria. Subsequently, as a GAAD research scholar, he had a remarkable stay for post-fellowship training in cardiology at the Eberhard Karl University, Tübingen, Germany, where he had a Doctor of Medicine qualification. He is a Fellow of the American College of Cardiology, Fellow of the European Society of Cardiology, and Fellow International Society for Hypertension. A round of applause for him. Professor Akintunde has over 130 published articles, including book chapters articles in learned journals, and technical reports. He also has one whole patent to his credit. He is a reviewer for several local and international journals. He began his teaching career as a senior lecturer in the Department of Medicine, Akintunde University of Technology, in 2011. He was promoted to reader in 2017 and made a professor of cardiovascular medicine on October 1st, 2020. His research bias has been on hypertension and the clustering of cardiovascular risk factors, their stratification and management. These dovetail into heart failure, rheumatic, ocular heart disease, and its genomics. Professor Akintunde has been involved in the iron deficiency anemia in heart failure study. Also in SIREM, INTER, CHF study, INVICTU study, among others. He presently leads the Nigerian Clinical Lipid Research Group. This is a group of researchers across Nigeria working to unravel more information on lipids and lipid abnormalities in the country. Professor Akintunde has received several awards and scholarships from local to international organizations, namely International Society of Hypertension, German Academic Exchange Service, OAU Malaysia, Apex Club Scholarship, among others. He has also won many grants to work on cardiovascular risk factors, including the Senate Research Grant, INTER-CHF Study, Grant Challenges, Canada, University of Western Ontario, Canada, Tertiary Education Fund, Institution-Based Research, 2016-2017, on the one hand, 2018-2019 on the other hand, and recently, 2023-2024. He has also worked in various capacities within the university as acting head of the department, which was between 2019-2020 and thereafter, August 2011 to July 2013. He also served as Deputy Dean, Faculty of Clinical Sciences, College of Health Sciences between August 2018 and May 2019. He as well served as Acting Dean, Faculty of Clinical Sciences between May 2019 and August of the same year. He is a member, Historical and Prospective Committee, College of Health Sciences, Akintunde University of Technology between 2011 and 2013, and Chairman of the College Timetable Committee from 2019 to a date. Professor Akintunde has served in various professional capacities, some of which include Associate Editor of the Nigerian Journal of Cardiology, second-term member of the African Regional Advisory Group of the International Society for Hypertension, Chairman, Editorial Board of the Integrated Journal of Medicine and Medical Sciences, and Course Lecturer, West African College of Physicians, Update Course for International Medicine, Cardiology for 2017-2018 and till date. He is also the course director of the African Hypertension School for the Management of Hypertension by Non-Physician Health Workers, an initiative of the African Regional Advisory Group of the International Society of Hypertension since the year 2022 to date. He is a state coordinator of the Nigerian Hypertension Society and the incumbent publicity secretary of the Nigerian Cardiac Society since the year 2022. Professor Akintunde is a member of many prestigious professional organizations, including the Nigerian Medical Association, NMA, Academic Staff Union of Universities, ASU, Nigeria Hypertension Society, NHS, European Society of Cardiology, International Forum for Hypertension Control and Prevention in Africa, Royal College of Physicians, Edinburgh, International Society of Hypertension, ISH, American College of Cardiology, Council on Hypertension of the European Society of Cardiology, Heart Failure Association of the European Society of Cardiology, Pan-African Society of Cardiology, and Nigerian Cardiac Society. He is also a member of the Christian Medical and Dental Association of Nigeria, the Medical and Dental Consultants Association of Nigeria, and the Nigerian Association of Medical and Dental Academics. Just as he is a fulfilled academic, clinician, and leader, Professor Akintunde is a responsible, loving, and caring husband to Dr. Mrs. Temitope Shade Akintunde, an associate professor of economics at Osun State University, Osogbo. Their marriage is blessed with two lovely children, Oluwani and Temiloluwa. Ladies and gentlemen, on this note, as I invite Professor Adeseye Abiodun Akintunde to deliver his inaugural lecture on this day, May 22, 2025, on behalf of the Vice Chancellor of this great university, Professor R.O. Rom-Kalilu, I declare the 64th inaugural lecture of Ladoke Akintola University of Technology of Ogbomoso open. Thank you.
Vice Chancellor, sir, Deputy Vice Chancellor, Academics and Innovation, Deputy Vice Chancellor, Strategy and Development, the Registrar, the University Librarian, the University Bursar, Provost College of Health Sciences, Provost College of Agricultural Science and Natural Resources, the Dean of the Faculty of Computer Sciences, Dean of other faculties, Postgraduate School and Student Affairs, Professors and members of the Senate, His Imperial Majesties and Royal Highnesses, my Lord Spiritual and Temporal, members of my nuclear and extended families, esteemed guests, friends and relatives, greatest Ladokites, gentlemen of the press and electronic media, distinguished ladies and gentlemen. Mr. Vice Chancellor, I feel honored and privileged to be the inaugural lecturer of today. And to God, from whom I have received all the mercies that have brought me this far, I owe all the praise. An inaugural lecture is an auspicious occasion for the university to acknowledge the appointment of or promotion of new full professors, introduce them to the academic and non-academic community, and provide opportunities for engagement with the broader community. Therefore, today, I would like to present a synopsis of my academic journey as a professor of medicine and share a glimpse of my future research projections. My story is exemplified by the biblical passage in 1 Samuel chapter 2, verse 8. He raises the poor from the dust and lifts the beggar from the ash heap to set them among princes and make them inherit the throne of glory. Mr. Vice Chancellor, please permit me to appreciate you and the university community for the opportunity to deliver deliver this inaugural lecture today on behalf of the Faculty of Clinical Sciences. This is the first from the Department of Medicine, which comes from the Department of Cardiology, the sixth from the Faculty of Clinical Sciences, and the eighth from the College of Health Sciences. In this regard, the roadmap for this lecture will be as follows. 1, my training, my call and career. Number 2, the stewardship of my scholarship. And 3, research agenda for the future. Mr. Vice Chancellor, sir, the title of this inaugural lecture was carefully chosen to bring to fore the decrepitude of scenarios in our world, where heart disease is rapidly becoming a common cause of death, not only in developed nations, but also in low and middle-income countries like ours, and the urgent need to combat it with a multifaceted approach to enhance the quality of life of our people. This topic reflects the overwhelming and continuous whispers of disorders that disrupt the harmonious and melodious function of the heart. These disorders are exemplified the Chaff in the Biblical passage that is in Matthew chapter 13, verse 24 to 43. It emphasizes, therefore, the call to fortify our defense fortress to enhance wellness against this rising scourge. I would therefore highlight my contributions to knowledge in early identification, risk stratification, and treatment of heart disease across Nigeria. During this time, majority of heart disease remain asymptomatic because the template for heart disease, which sometimes is atherosclerosis, may take up to 30 years to evolve into major complication. And the margin is a stitch in time saves 9. As one of the organs in the body, the heart was long identified as the center of the entire body. The human heart is viewed from the front as shown in figure 1, while figure 2 and figure 3 shows the different phases of what they call the cardiac cycle. What is heart disease and how can it be treated? Mr. Vice Chancellor, sir. Cardiovascular disease is a group of diseases that affect the heart and of blood vessels. The World Health Organization revealed in 2016 that Nigeria, non-communicable disease, which include strokes, diabetes, contribute about 11% of the total disease body. And this disease can be caused by a combination of factors, which include behavioral, socio-economic, and environmental risk factors. Heart disease can be dated back to as long as 3,500 years ago, when Pharaoh Merenta, who died sometimes in 1203 BC, was actually seen to be plagued by this atherosclerosis. Researchers asked the question, how could this be possible? But it suggested that the average Egyptian could have eaten a lot of fatty diets, including geese and fatty milk. The experience of the United States president in 1955 and his subsequent death from heart failure in 1969 worried a nation that knew there was little to be done to prevent heart attack and heart disease. And it became somewhat of a turning point in care, because as for prevention at that time, nothing was in place until the advent of the Framingham Heart Study in 1948, when doctors began to understand that the root causes of heart disease are related possibly to diet and our environment. Again, the natural history of hypertension is also illustrated by another United States president, Franklin Delano Roosevelt. In 1937, when he became president, his blood pressure was 162/98. And consistent with medical knowledge as of that time, nothing was done for that blood pressure. His blood pressure subsequently reached 180/80. And by 1943 and 1944, his failing health led to speculation in the press regarding his competence to continue in office. By that time, he had developed heart failure and shortness of breath. He subsequently died of a stroke in 1945, and his blood pressure was 300/190. That tells of the progression of the blood pressure and other changes as it leads to eventually heart disease. Learning to detect heart disease, the lesson of the century. So many things have evolved about how we discover disease. Many investigations discovered by Mason Soames, a pediatric cardiologist, highlighted how to diagnose coronary artery disease. And today, several invasive and non-invasive tests are available, not only to detect the disease, but also to predict the progression of the disease. We need to be armed with sufficient knowledge to be able to predict this disease as before they evolve into major catastrophes. We started watching our diet sometimes after the Framingham study came up. And it was one of the first studies that related diet to the development of heart disease. Again, sometimes in 1950, Ansel Keys observed during his travels that people in Japan and the Mediterranean regions sometimes have no burden of heart disease. And he suggested that because they were taking low saturated fat in those places. The most important thing is the future of heart disease. Because as it evolved over the years, as diagnostic investigation evolved, we come to learn more. Today, we know how to treat many of these diseases and improve the quality of life. But we don't yet know it all. And we're still a long way from completing erasing heart disease from one issue. The future of heart disease is prediction before it happens. Because that is exactly where the world should be going. And that is why this topic is very important. The message, therefore, I would like to reiterate throughout this lecture is to highlight the significance of early detection and treatment of these risk factors before they evolve into major catastrophes. The truth is, do not allow the chaff to grow with the wheat. Look for it and cut it down. Know your numbers and heart. Our God intends that our hearts are healthy. In the words of King Solomon, Proverbs 4 verse 2, he says, keep your heart with all diligence, for out of it are the issues of life. The interplay between heart disease, lifestyle, personality, and clinical outcome is also exemplified in the Holy Book. The biblical account of Nabal's ostentatious lifestyle, his personality and cruelty, vividly describe how heart disease might have been the cause of his death. In 1 Samuel chapter 25, verse 37, the Bible says, it came to pass in the morning, when the wine was gone out of Nabal, and his wife had told him these things, that his heart died within him, and he became as a stone. His heart burst of passion on hearing that his will had been thwarted, brought on a fit of apoplexy, in which he lingered insensibly for 10 days, until he eventually passed on. And as the Bible says, after about 10 days, the Lord struck Nabal and he died. The parable of the wheat and the wheat, upon which this topic is found in Matthew chapter 13, verse 24 to 30. He said another parable before them, saying the kingdom of heaven is like a man who sowed good seed in his field. But while people slept, his enemy came and sowed wheat among them and went away. While the heart is designed to be like an enchanted garden of well-being, hypertension and heart disease, along with their multiple risk factors, emerge as relentless chaffs, entangling their roots deeply within the soil of our existence. And like an insidious sorcerer, they cast a spell of pressure upon our vital spheres. They challenge the equilibrium of the mind and the body. And to break free from this enchantment, we must wield our magical tools of healthy habits and wise choices to restore the garden to its flourishing state of balance and vitality. Mr. Vice Chancellor, the whole sole aim, again, is to highlight my contribution to identifying, treating, managing, and preventing this deadly scourge, a menace that is disturbing the harmony of many lives and leading to major catastrophes. This is due not only to the act of the so-called devils, but also to the devils of our choices in what we eat, how we live, and what we choose to do or not to. This is without prejudice, acknowledging the non-modifiable genetic disposition to many of these heart diseases. The truth is that while heart disease develops suddenly, it takes a long time for the child planted by the abnormal choices of life to grow into fully developed chaffs, often becoming an irreversible seed and trend of complex interaction and adaptation for the normal heart to function. This lecture therefore calls us to rise and prevent these chaffs from being planted in the first place. And if they are eventually found, we must learn how to nurture our hearts successfully against the venomous whispers of these disorders, entrenching a wall of strong defense until a good harvest is obtained. Mr. Vice Chancellor, sir, my training, my call, and career, my voyage in medicine is at best a divine ordination, crafted by God, even when I did not fully understand what it meant to be a medical doctor, let alone a cardiologist. I fell in love with cardiology during my medical course at OAU, and interacting with Professors M.O. Balogun and A.O. Akintunde gave me the driving impetus I needed to specialize in cardiology as a medical student. I loved the calm, the clean, and peaceful ambience of working with them. And I was fascinated by that I could be useful to many people, especially with those with heart disease. At around the same time, my beloved grandmother, Mrs. Amokeshola Devi, was diagnosed with heart failure. And my observation of how she was treated further solidified my decision. The stewardship of my scholarship. In the kingdom of earth, where the heart reigns supreme, hypertension, heart failure, and other heart disease lurk as cunning traitors, seeking to overthrow balance and harmony, and disrupting the rhythm of life grand symphony. Only by uniting our forces and fortifying the fortress of wellness can we stand against these treacherous invaders. Heart diseases are the unwelcome guests at life's delicate banquets. They arrive uninvited. They turn the placid water of tranquility into turbulent ones. And they have relentless pounding on the castle gates of our hearts that demand vigilance. By fortifying our defense with mindfulness and wholesome living, we can take this unruly intruder and restoring serenity to the banquet and harmony to our existence. My contributions to cardiovascular medicine. Risk stratification in heart disease. Risk stratification involves grading a patient into incremental levels of risk and can be defined as a process of medical decision. Figure 4 shows the temporal profile of many heart diseases, and that's exactly how it looks like. Heart disease can last or can evolve over 30 to 40 years. During this process, these risk factors are there, they may not have any symptoms until they evolve into a major stroke, a kidney failure, or an heart failure. So it's important to pick them, and all of them, a lot of them are asymptomatic. The truth is, we need to evaluate ourselves regularly. We've also done a lot of work on hypertension and clustering of risk factors. Hypertension rarely exists alone. This clustering is referred to as metabolic syndrome because it's associated with urbanization. One of the significant drivers of heart disease is obesity. And sometimes in 2010, in a cross-sectional study of more than 1,110 patients, we showed that a lot of our patients are hypertensive. 25.5% were obese. And that corresponds, that is related to their risk. Again, they had to respond to hypertension and obesity with different and specific cardiac adaptation. Akintunde in 2013 conducted a cross-sectional study of 313 patients with hypertension using echocardiography and showed that a lot of these patients, especially obese women particularly, had increased left ventricular mass index, and these are very, very important. Again, in 2010, we determined the prevalence of dyslipidemia, which is abnormal cholesterol, among newly diagnosed hypertension. And we showed that more than half of all hypertension presenting fresh had associated elevated cholesterol. And in another study, the presence of impaired glucose tolerance, which is a precursor to developing diabetes, is about 30%. So wherever you find one, you are always likely going to find the other ones. Every time you see hypertension, you must look for express blood. They almost always work together. And many times, you need to look at them. There are many other risk factors that we have look like. That is risk stratification. We talk about QTC and increased QT dispersion. These are markers of substantial cardiovascular mortality. And it has been shown that a lot of our hypertensive patients have substantially increased parameter in this way. The proportion of cluster risk factors that is very common among these patients include hypertension, obesity, and low HDL lipoprotein. Of course, we also look at cardiometabolic risk factors and metabolic syndrome in the population and the level of knowledge. Like I said, metabolic syndrome is the clustering of those risk factors. And anytime, anywhere they are always associated with substantial increase. Adeseye and Akintunde in 2012 explored this among native Abuja settlers, and we showed that urbanization, living in an urban center, is associated with increased clustering of cardiovascular risk factors. Metabolic syndrome was found in 14.9% compared to the rural people that lived about 7.7%. and all the proportion of the lipid profile was substantially increased in genetically related Abuja settlers in that study. Again, we also showed that urbanization is associated with higher prevalence of dyslipidemia, and these were very, very significant as shown in table 3. Sequel to some events in our university, Mr. Vice Chancellor, sometimes in 2011 and 2014, we sought a university research Senate grant to describe the pattern of cardiovascular risk factors among our university staff here, who were apparently healthy. The results, I must say, were daunting, and highlighted the importance of early identification and appropriate treatment. A cross-sectional sample survey of 206 university staff showed that the prevalence of all these risk factors was substantially higher than the population prevalence. It suggests that even university staff are at an increased risk, and it's a call to the National Association of Women in Academics, ASU, LAUTECH, NASU, and the management to champion the cause of increasing health awareness and evaluation among our staff. Again, we determine how much knowledge people have about heart disease, and we show that quite a whole lot of people in the university did not have appropriate knowledge about the relationship between risk factors and heart failure and diabetes, and that is something of a very great concern. I have also highlighted the disparities in profile of heart disease between genders. Our research has described the gender-specific pattern of heart diseases and corroborated the fact that women may be more at risk of heart disease. Because women experience unique lifestyle changes, such as pregnancy and menopause, and this can put them at an increased risk for heart disease. There is a need to constantly raise awareness for treatment and control of hypertension in Nigeria. Over some years, the main measurement month, we determined the prevalence of hypertension across Nigeria. And using the MMM score, we scaled about 9,261. Hypertension was present in 34.1% of the participants. Mr. Vice Chancellor, one message that resonates throughout this study is that cardiovascular risk is a continuum. It doesn't start one day. Those risk factors are always there, silent and keeping quiet. We need to look for them, address them before they evolve into disease. And that is the reason for to raise effective medium for integrated strategies to reduce the burden by encouraging early prevention among the population. We've also done a lot of studies among our hypertensive subjects using echocardiography. In a study, we discovered that a lot of our hypertensive subjects, up to 25% of them, 2009, had diastolic dysfunction. And that the factors that determine those dysfunctions included their age, the level of systolic blood pressure, and other left chamber dimensions. We also documented that their left ventricular parameters may also be related to the eventual dysfunction that occurs in them. Identified that patients with left ventricular geometric abnormalities, called eccentric hypertrophy, which is a particular type of geometric abnormality, is an early precursor to somebody developing heart failure, just to pick people before they eventually develop into heart failure. Again, in 2012, we documented the correlational use of the Global Myocardial Performance Index, called the TI index, and we reported that it was correlated significantly with many of the cardiovascular risk factors. Again, carotid atherosclerosis, that is thickening of the carotid arteries, can often precede a stroke, and we can predict somebody that will develop a stroke simply by measuring the thickness of the carotid intima media thickness. Sometimes, in 2013, we examined the usefulness of this parameter as a surrogate marker, and Akintunde in 2013 established its usefulness in hypertensive subjects. A simple measure of that CMT using an ultrasound machine can actually predict your risk of developing a stroke and help you to inform to take preventive strategies which can be life-saving. Again, another marker is aortic root dilatation, and when that dilatation occurs, it indicates an increased cardiovascular risk. we showed that in our patient, Akintunde 2013, aortic dilatation was significantly associated with many cardiovascular risk factors, which included age, waist-hip ratio, left ventricular mass index, and left ventricular chamber dimension. One heart disease that is becoming very rampant is heart failure, and it is a syndrome that is characterized by structural or functional abnormality. Our survey, back sometimes to 2012, suggests that there is a changing pattern of heart disease. In Osogbo, we documented about 45% of all our patients having non-communicable disease. Again, in many of these heart failure, sometimes people think heart attack is not very common here. We look at the proportion of those heart failure who has had what may likely have been an ischemic heart disease, and documented that up to 13% of them will have actually had a previous myocardial infarction. The challenge is that a lot of them, or all of them, deny the history of chest pain, and it is possible that risk, our genetics or our environment might have been the risk factor. One case out of so many that I have seen was a scenario, was a patient of mine, a middle-aged man from a village in Osun State with a 3-vessel disease and angiography, which is the most severe form of ischemic heart disease, and he denied any history of chest pain. He was referred for angiography and coronary intervention, and is doing very fine today. I'm sure somewhere it's either here or online. We therefore suggest that Africans may not always present with the typical chest pain of acute myocardial infarction, or it's possible that they have been wrongly diagnosed, and they could still present and go ahead to develop heart failure later in life. Well, the contribution of rheumatic heart disease to heart failure has also been emphasized in studies by our group. Rheumatic heart disease, and it has damage of the valve, and is the second commonest cause of heart failure. We reported in the inter-CHF study, where I was a major site investigator, that rheumatic heart disease is the second commonest, and that our patients have very poor temporal profile and clinical outcome. This poor clinical outcome were related to the presence of comorbidities that occurred in heart failure. Mr. Vice Chancellor, sir, I have studied many of these comorbidities in heart failure, and have shown that a large proportion of heart failure patients have very many of them. In the iron deficiency anemia in heart failure study, which is a pioneer interventional study in Africa of iron deficiency by Akintunde, we demonstrated iron deficiency occurring in up to 60% of heart failure patients, and almost all of them, up to 93.7%, have at least 2 or more of the 13 comorbid factors that were studied. We also observed that a lot of them had snoring and obstructive sleep apnea. So that snoring itself is a risk for heart disease. When you snore and when you have heart disease, you are likely going to have, a higher body. In a first of its kind randomized controlled study in African continent, parenteral iron therapy was administered to 30 heart failure patients with iron deficiency by Akintunde in 2015, with significant improvement in outcome. We demonstrated that parenteral iron therapy was fairly well tolerated among these patients, and that iron replacement was actually with improved quality of life, a better temporal clinical profile, and an improved functional classification among our patients. Akintunde in 2021. We therefore recommend that regular iron screening and parenteral iron infusion may be a potential way to reduce death from heart failure in our continent. We have also demonstrated that a lot of heart failure patients have clustered atrial fibrillation, and that can also, affect their outcome. One of the other areas of study that we have been involved in is pharmacotherapy of hypertension, which including resistant hypertension. One of the commonest and the most important things is how to get regular drug compliance. Low adherence was documented in 42.9 of those attending a general patient clinic, compared to 15.2 in a cardiac specialist clinic. We therefore recommended that enhancement for regular drug adherence should be enhanced. Again, we looked at plasma renin and aldosterone level, and in another landmark study, Akintunde determined the normative values of plasma renin and serum aldosterone amongst school teachers in Ogbomoso, Nigeria. The prevalence of high aldosterone ratio was 10.8, and we concluded that Nigerians most likely have a low renin profile. Together with research associates in Canada and South Africa, 6 candidate genes associated with low renin hypertension were sequenced, and this phenotypic approach was used to engender a study. The preliminary study suggests that this approach may be useful in understanding the genetic architecture of residual hypertension in blacks, and it formed the basis of its first of its kind study in Africa, where patients in hypertension clinic only at Hospital of Bomashaw, Kenya, and South Africa with residual hypertension were allocated to usual care versus physiologically individualized care. After 1 year, we concluded that those that were randomized to physiologically individualized therapy performed better. Akintunde 2017. Heart disease and diabetes, they are the two sides of the same coin. As heart disease, cardiovascular disease is responsible for more than 70% of patients in patients with type 2 diabetes. But the awareness of this risk is very, very low. We analyzed data from 4 population-based cross-sectional studies from the 6 geopolitical zones of Nigeria, and we showed that the overall prevalence of impaired fasting glucose and diabetes was 5.8 and 3.1%. We conclude that the higher prevalence and comorbidity of impaired fasting glucose and diabetes highlight the need for the risk assessment for people before they develop diabetes, because that's when these risk factors actually coexist and intervention actually evolve. In another study, we looked at abnormal blood pressure dipping pattern and showed that 85% of our patients have abnormal blood pressure dipping pattern, which is a cardiovascular risk itself. The necessity of fast steering in the management of hypertension and heart disease. It's not gainsaying that our health system has suffered several setbacks with Chaff, and it is vastly under resources. The Regional Advisory Group of International Center of Hypertension considered that existence and started the African School of Hypertension for Non-Physician Health Workers. I was appointed the director of that school, and we trained the first set of non-physician health workers on the rudiment of managing hypertension under my leadership of that school. The first session of that school was held in 2023, and we certified 92 participants, endorsed by ISH and Inaugural Academy, from 7 African countries: Nigeria, Kenya, Gambia, Cameroon, Malawi, Sudan, Tanzania, and Ghana. It was a major news report at the ISH on that weekend, and I'm very proud to have led that feat together with other faculties across Africa. Cardiovascular risk in the population. Mr. Vice Chancellor, my emphasis on tackling these myriads have sometimes recently changed into our population, and permit me to report some of our findings in this area. Children of people with hypertension, they tend to have an increased risk even before they develop, they go into adulthood. Akintunde in 2020 went to secondary schools in Bomashaw and discovered among students that offspring of hypertension had abnormal left ventricular geometric structure and increased left ventricular mass, even as a child, exposing them to risk and making them targets for developing this risk. Unfortunately, a lot of things need to be done to change this. Again, air pollution has become a major global issue. And one of the trades that we looked at Gary workers in Bomashaw, we went to their factories and sampled and discovered that the air quality index and prevalence of respiratory symptoms in them were very, very high. And a lot of them are predisposed to developing heart disease simply because of the air pollution around them. Again, we have looked at school teachers because their work is related to the performance of our children. And we showed that school teachers in 5 local governments in Bomashaw were reported to have, many of them were reported to have very high cardiovascular risk, despite, compared to the other population. We have also worked among auto mechanics because they have prolonged inhalational injury because of the things that they work with and they do with their hand. Akintunde used 103 auto mechanics information and a 5-day serialized measurement, which showed an increased particulate matter compared to the national minimum, 10 times the average minimum in their workshop. And a lot of them have substantial increase in cardiovascular risk. One would suggest that because of the nature of their work, they are going to have a very low risk, but unfortunately, that is not what we find. Again, heart disease and stroke, which is a double jeopardy. Heart disease and stroke occurs, and stroke commonly occurs in Africa. They are like, again, two-edged sword. I have participated in many research on the two divide. One of the largest stroke studies in Africa is the silent study. And we documented that traditional risk factors that are responsible for stroke, 95% of them are related to factors like elevated blood pressure, diabetes, obesity, and smoking. In another study, we analyzed the relationship of second-hand smoking exposure, that is passive smoking, and showed that people who are passive smokers, hanging around smokers, they have an increased risk of stroke simply by second-hand smoking. So whether you smoke or you stand in front of the smoker, you are also a smoker and you run the same risk. Well, when smoke occurs repeatedly, we decided, we look at the risk factors that determine the occurrence and discover that many of the modifiable lifestyle risk factors, including hypertension, diabetes, are essentially the target for prevention. Let me say for the opting time that cardiovascular diseases are often preceded by many years with clusters of these risk factors. And only early identification, treatment, and modification appears to be the major way to avert this looming epidemic in our continent. Simply because we may not be able to afford the treatment of heart disease in its numbers. So the maxim is therefore a stitch in time saves life. Please know your number. Again, we've looked at rheumatic heart disease and its impact in Nigeria, and we've shown that this is very common. Recently, in the Invictus trial, we reported that our local warfarin is actually as better, non-inferior to the novel oral anticoagulant agent in a landmark study that lasted for about 4 or 5 years. And I'm happy to note that about 40 of our patients with commercial benefited from that study. A national effort is required to protect future generations from the scourge of rheumatic heart disease. Only through active surveillance and antibiotic prophylaxis. When your child has tonsillitis, please give antibiotics, not malaria, not anti-malaria. And that is the way to treat the future generation for rheumatic heart disease. The time to act is now, because that has been helpful in countries like Nepal and Cuba. For a nation that's over 230 million, there is an urgent need to call the attention of critical stakeholders to this. Sudden cardiac death and its prevention. Mr. Vice Chancellor, sir, the trend of sudden death is on the rise in our environment, and our university and immediate community has not been scared. It is the unexpected, non-traumatic death occurring within an hour, and the majority are related to heart disease and stroke. A lot of them are not often unexpected, and the impact of many of these subtle risk factors, including urbanization, air pollution, physical inactivity, and potentially turbulent newer risk factors, requires that we must be on the alert to deal with them. An ounce of prevention is worth a pound of cure. Don't put what you can do today. Please afford yourself screening. My routine clinical observation and advice. I come to learn, Mr. Vice Chancellor, that heart disease are very much with us, and that is a synopsis of how to prevent heart disease. 10 steps to prevent heart disease. You need to manage your blood sugar if you have one. You need to see your doctor for regular check. You need to be on the move. Take breaks. Leave that car. Move. Take a move. The advice is take 30 minutes or 40 minutes of exercise daily. And this organization is catching us, starting with us, and has disease on the increase. You need to be on the move. You must be smoked with. I talk about passive smoking. If you live with a smoker, you are a smoker. You are the of course, you must maintain a healthy weight. You must maintain a healthy weight. You know, alcohol, absolutely no alcohol. And of course, I think it's important to reduce your stress. What can you then do to reduce your risk of heart disease? As we have said, a lot of them are very, very preventable. Of course, I've mentioned quite a whole lot of them. You must know your numbers. Knowing your numbers is an important part of keeping your health healthy. Regularly checking your blood pressure, your cholesterol level, your blood sugar, help you to determine the risk that you run and control that risk and prevent sudden development of heart disease. Knowing your blood pressure is one of the biggest causes hypertension is actually one of the biggest causes of heart disease. Hypertension doesn't have any symptom. So get checked, get evaluated, and of course again, know your cholesterol, know your body mass index. Again, if you have heart disease, please take your medication as prescribed. And of course, know the warning signs. My contributions to manpower development in Nigeria and globally. Mr. Vice Chancellor, sir, I have participated in the training of medical students at the Lab of Abiodun University of Technology from 2003 to today. I've also participated in the medical student training at Howard University as an associate lecturer since 2012. I have also supervised the training of 5 fellows in cardiology. Dr. Peters Johnson, Amechi, Yusuf Oladusi, Karim, and Olawale Matal, including many physicians. And I've mentored many outside my local workplace across the nation, many of whom are working in Nigeria and abroad. I'm currently supervising 3 senior registrars in cardiology, Dr. Shope Orugun, Abubakar Usman, and Adeyemi Emmanuel, among many others, across the nation, to whom I also serve as an academic mentor. I have served as an extra examiner at the final MBBS exam of several universities, including the University of Ilorin, Afebabalola University, Babcock University, Edition and Remo. I've also served on the professorial review panel of the University of Ilorin and Bowen University. I've also been the first coordinator of the African School of Potential, and I train non-fictional workers. Also as an examiner of West African College Part 1 and Part 2 from 2018 to today, I'm part of the National Postgraduate Medical College of Nigeria Acquisition Panel for membership training. My future projections are research focused. Mr. Vice Chancellor, let me reiterate that it's my intention, God willing, to continue to contribute my quota to advancement of knowledge on the causes and treatment of heart disease on this continent and globally. Many questions still exist on the relationship, causes, and the peculiarities as Africans when it comes to heart disease. And I hope to further contribute to the development of heart disease, hypertension, and heart failure. My concluding thoughts. Mr. Vice Chancellor, permit me to say that heart disease is not all about you. The main lesson is that risk factors often precede this disease for many years. And even though many of them are asymptomatic, they don't have any symptoms. If you got a headache, it's not from hypertension. If you got chest pain, no. Your blood pressure can be as high as 300, you may not have any symptoms. So the only way, please check it. And you can take advantage sometimes, for in this program outside. People with cardiovascular disease are already, as we have shown from several of our studies, in Nigeria already at high cardiovascular risk. And it predicts that the future may be blue if we do not start to take action immediately. How do we do that? My recommendations. For individuals, if you are sitting here today, please know heart disease are often preceded by risk factors for many years and possibly decades. And there is need to take personal responsibilities for your health. No one cares for you in this issue. Check your blood pressure. You must check it because you hold your life. Regular screening for these risk factors and taking appropriate measures to combat it is the reason for the Know Your Numbers campaign. And for the community, we must develop strategic partnerships between critical stakeholders that can help to integrate cardiovascular care into things like antenatal care, HIV care, so that it can be easily procured. Then the community must also institutionalize periodic, regular checkups, and it must be widespread, either statewide or nationwide, either as a matter of campaign to check for people's blood pressure, blood sugar, and other risk factors. And for the government, we must include cardiovascular care in the NHIs. I encourage that we should increase financing for sick care, and also adopt a tax sharing and tax shifting model for cardiovascular care. My colleague, Mr. Vice Chancellor, sir, delivering this inaugural lecture comes with some trepidation. And one of them is how to capture the depth of the magnitude that has brought me this far. From the peasant little boy selling a pool and provisions for my sisters, some of whom are in the audience here, to how I rose to the pinnacle of his academic career, only been by God who makes all things possible. I would like to pay special tribute to my grandparents, late by David Soladebe and Mrs. Amoke Soladebe, under whose care I enjoyed so much care and affection. They laid the foundation of what we are celebrating today. They invested heavily in my education, and not more with an uncommon support. And how great it would have been if you are here today. To my parents, the late Mr. Michael Adego Akintunde and Mrs. Felicia Lokwe, please stand up. That's my mom. Thank you very much. God bless you. To my siblings, Mr. and Mrs. Gideon Mokola, Ayolani, Bukola Adeyemi, Bukola Akintunde, Mr. and Mrs. Adedino, Segun Akintunde, Dr. and Mrs. Kule Faniran, and Mr. and Mrs. Oluwafemi Akintunde. I appreciate all of you. I also like to thank my esteemed cardiology teachers, upon whose shoulders I have leaned on to get to this eye. Professor Oladimeji of George Okadijo and Professor Mrs. Patience Ademusi are here. Ademusi is here today. Please stand up. Thank you very much. They are two of my excellent teachers and guides in the part of cardiology. They provided the knowledge and support all the way. And from teaching clinicals to learning how to write articles, to be able to take responsibilities on your behalf, I say very big thank you, sir, ma'am. To my other teachers in cardiology, Professor Emi Balogun, Eo Akintunde, Leslie Ajayi, Obi Familoni, Ebi Womotosho, and Mayada Gawat, thank you for your impactful resilience and doggedness. I hope many of you stars and mass immense gratitude for your sacrifice. God bless you. I would also like to thank my other teachers in medicine, Professor Oya Yodele, Emo Tanimawu, and many others. Thank you very much, sirs. God bless you. To my colleagues, Professors Philip Adebayo, Abiodun Jemilo, Michael Olamoyiko, Doctors Okoyomi Oni, G.M. Israel, Odipo Oje, Abukari Ishitu, thank you for being good partners and colleagues. To all the resident doctors in the Department of Internal Medicine, Doctors Shokweto, Abubakar Ismail, Emmanuel Adeyemi, Taiwo Adeyemi, Oyewusi, Idris and Kenneth Kolo, a very big thank you. And to all the staff of BCG and the Medical Application Department, thank you. You are well appreciated. I would also like to acknowledge with immense appreciation a worthy mentor in the person of Dr. Okechukwu Oga. I traveled to meet him at FMC Abiodun for the first time in 2006. His warm reception and his pragmatic willingness to mentor young ones culminated in my getting the Dorsey Academia Outstouch guest in scholarship in 2008. I would like to put on record the immense contribution of that scholarship in my academic career, as it has greatly affected and massively influenced my research work and provided support in terms of groups, collaboration, and platform up to date. Thanks to the German government for this work. To other corporate bodies that have supported me in my research career, including the Canadian Institute of Health Research, universities, that's the London Universities Research and Consultancy Services, the Tertiary Education Fund, Institute of Health USA, and many other pharmaceutical companies, I say a big thank you. I would like to appreciate some of our research collaborators and members of the Nigerian Clinical Epidemiology Research Network across many teaching hospitals and executives of the Nigerian Cancer Society, with whom I have been privileged to serve on the executive board to tackle diseases across Africa. Teachers are the backbone of education. They shape mind. They inspire futures with patience, dedication, and wisdom. Their impact reaches beyond their books. They instill values. They ignite curiosity and fostering dreams. My sincere thanks to my teachers from the Credo Baptist Baptist Primary School, Ogbomoso, and Ogbomoso Grammar School. And to my school principal, Mr. Akintunde, I'm not sure he's here. I'd like to say thank you very much for your penchant for excellence and your strict disciplinary spirit has only pushed us further the ladder of life. I celebrate you today and my other teachers, including Mr. Isolini, Mr. M. Makide, Mr. Makide there. Thank you very much, sir. Amoshai, Pastor Badari, Mr. Oglo, and Professor Awodiba. To my old friends and colleagues from Baptist Primary School and Ogbomoso Grammar School, some of them are here today. Samson Oladapo, Oluwole Adeyemi, John Alagbe, and Dr. Tunde Adegoke, very special senior colleague. Thank you very much. To lead the men, 2001 group, both home and abroad, represented by great cousin and others, Dr. Tunde Ogudari, Dr. Samuel Adegoke, and my very good friend, Dr. Rufus Ojewala, and Tino, thank you very much. Appreciation to some of our trainees who have now become friends, especially Dr. Matthias, Olawale, Akintunde, Peter Johnson, Lukman Karim. I appreciate you immensely. Today, I would like to pay special tribute to my uncle, late Professor Johnson and deal with Akintunde. I know you would have loved to be here today, but keep resting in the bosom of our Lord's resurrection morning. I appreciate Baba, Jeremiah Akintunde, Mrs. R.M. Akintunde, and the entire Akintunde family from the other sources, Romban, Ara, and members of the Ara descendant here. Thank you very much. So the Shalade means from the last number, Abogode Ogbomoso. I say it was a great pleasure growing up with you. Thank you and God bless you. To the KBSCs and the Oloris, thank you very much, sirs. My Lord spiritual and temporal, to friends from Baptist Church, Rema Baptist Church, Oshogo, Baptist Student Fellowship, OAU, and the entire Baptist family under the Nigerian Baptist Convention, the MMU from Oshogo Baptist Conferences, every day represented, and thank you very much. To our loved ones from everywhere, I say very good, thank you. Let me put on record my immense gratitude to all my patients and research associates, as you have provided a platform for my expression of what I have been endowed with, and I'm eternally grateful for every opportunity of working together with all of you. I would like to thank and appreciate especially my in-laws, late Amos Onalako Oladejo and Deaconess Cecilia Olatorira Oladejo. Please stand up. Thank you very much, sir. For your support for me and my family over the years, we say the Lord bless you, man. To my wife siblings, Engineer and Dr. Mrs. Olusegun Oladejo, Dr. and Mrs. Ayobami Oladejo, Pastor Moses and late Mrs. Tosin Oladu, and Engineer Boyega and Mrs. Tulope Oladejo, thank you very much. To my friends and colleagues from Lautech and Lautech Teaching Hospital, Bowen Teaching Hospital, I can see Mr. Ali Jaya, thank you very much, sir. From Nigerian Catholic Society, West African Doctor of Physicians, and to staff of Ocean Clinic Oshogo, led by Mrs. Abiodun Oluwasegun, I say thank you for all your effort. For the great editorial input by great scholars, including Professor Akintunde, Professor Peter Olalaito, Dr. Sebastian Oiwa. Dr. Sebastian has traveled all the way from France to be here. I'm sure, thank you very much. I owe you, all of you, immense and deepest appreciation. For the planning committee of this event, for a great job and your pragmatism, ably led by Dr. Tunde Alabi, I say very good. Thank you. For my special friends and children, Toluwani Adeseye and Temilo Aderishola, please stand up. No matter how big or small, you are my greatest God. And watching you grow, learn and become your own person, fill me with pride. I want you to always know that you are loved, cherished, and deeply valued. You make my love brighter every single day. Sometimes you ask me why I am always sitting behind the computer, reading and writing after coming often from a long day's job. And as I try to joke with you, being a father with the huge demands of a clinician doctor, a researcher, and a teacher combined, this day is a testament to the long years of hard work. You brought immense joy to us And may God continue to preserve you and keep you well. I had a personal assistant whom I met 28 years ago as a lady. Then she was a friend. Later she became a life companion. The story of our togetherness has led her from a major economics education platform to pure economics and thereafter to health economics. And we are bonded not only in mind and in spirit, but also in academic work. She is Dr. Mrs. Akintunde Shade Akintunde. Associate Professor of Health Economics from Akintunde University. This journey has been one of dedication, challenges, and triumph. But through every moment, your unwavering support, love, and belief in me have been my greatest strength. You have been my rock. You celebrate my successes. You uplift me in all my struggles. You encourage me to reach for heights I once thought impossible. Your sacrifices, patience, and love make today even more meaningful. And I dedicate this achievement not just to my effort alone, but to yours as well. You are my greatest partner, and I'm eternally grateful to you. Thank you, my Lord, for walking this journey with me. And to God, who doeth all things well, the fourth man in the fire, to the one whose love for me is eternally boundless, whose power is transcendent, who has simply made me an image of his glory to radiate exuberantly, to the ancient of days who made this day possible, and to whom all praise is due, I say Ebenezer, for the Lord has not done it. And like the Germans will say, vielen Dank, dass Sie alles gekommen sind. Gott segne Sie alles gut heimreisen. Thank you all for coming. God bless you.
On behalf of the Vice Chancellor of this great university, I declare the fourth inaugural lecture for the university closed. Thank you.
Anthem.
Progress. I see what